Hello, this is Dr. Craig Thomas. Thank you for joining me today. We're going to talk about color vision in diabetes, kind of an interesting topic. I thought it would be new and refreshing for the OD Wire membership. So we're going to start off quickly as a quick refresher. I do have some financial disclosures. I'm a paid consultant for Conan Medical and BioD. I won't be talking about either of those products in this presentation. So let's begin. Diabetes. We've all been to a bunch of diabetes classes and diabetes lectures through the years. I'm not going to spend too much time reviewing the disease of diabetes. Just a minimal refresher. I'm not going to also read slides to you. Everybody can see the slides. So we know what diabetes is and what diabetes does. Diabetes causes metabolic abnormalities. The ones we're primarily concerned about are the hyperglycemia, dyslipidemia, and a lot of information now on oxidative stress as a new thing that we're studying with diabetes. Also in a review, we have our current treatment guidelines. And the best treatment that we figured out to try to keep people from going blind is to make an earlier diagnosis of diabetes. And as optometrists, our primary goal is to help identify patients with diabetes, with the complications of diabetes, and to try to keep them from losing their vision from diabetes. The best way to do that is with an annual dilated retinal exam and the best metabolic control that you can have on the diabetes, either diet, exercise, medicine, or some combination of those three things. So a quick review on diabetes itself. What we're going to talk about is the manifestations of diabetes, the disease manifestation, the expression of diabetes. Not really the disease itself, but what the disease does to the body. And specifically what disease can do to the eye and the visual system. We see that diabetes can produce any of the following manifestations. We all are familiar with the refractive changes that we can get when the blood sugar is out of control. There's a type of glaucoma that's associated with people having diabetes. There's specific types of cataracts. There's the diabetic cataract that we all learned about in school. But I believe, based on my 30 plus years of clinical experience, that people with diabetes also have a higher incidence of regular age-related cataracts. We have the occasional cranial nerve palsy where somebody comes in with double vision. And of course, and I guess most importantly, diabetic retinopathy, the number one cause of blindness in our country. So, these are the things we have to be concerned about with diabetes, these manifestations. The primary manifestation, diabetic retinopathy, and I'm going to, if I read a slide to you, it's so important. It's almost like a test question. So I'm actually going to read this one. What is diabetic retinopathy? It's a microvascular complication of diabetes. And here's the key thing. All the literature, all of the guidelines, all of the rules define diabetic retinopathy as something we can see. It's an observation of these vascular lesions, the microaneurysms, the exudates, the circinate exudopathy, all the stuff that we see. You've got to see it to call it diabetic retinopathy. So diabetic retinopathy is the observation of vascular changes or these abnormal vascular lesions. What we know now is that diabetes-induced metabolic changes can also produce what's called neurodegeneration in the retina. It can produce neurodegeneration extraocularly. It can produce it any of the blood vessels in the body. We're all familiar with the peripheral neuropathy that our patients with diabetes get. So it's not just diabetic retinopathy, and it's not just stuff that we see that we have to be concerned about in our patients with diabetes. This chart is a really good kind of a explanation of the relationship and how diabetes causes these different things. And you see up in the upper left where it says retinal neurodegeneration. So we've got this early loss of vascular integrity. When the blood vessels start to seep fluid, we get early structural damage, and then we get a functional loss of vision. Simultaneously, and we don't really know if the natural history, if one leads to the other, if they happen kind of in a parallel course, but you also get the retinal vasculopathy, which is what we call diabetic retinopathy right now. That's the visible microaneurysms. You can see, especially with red free filters and other exam techniques, capillary non-perfusion. You can see neovascularization in the retina pretty easy with an ophthalmoscope or with white light fundus photography. This box up here, this retinal vasculopathy, that's what we're calling diabetic retinopathy right now. But it's also this retinal neurodegeneration, and you see, of course, it does all kind of other stuff to the body. You get this generalized neurodegeneration where all the nerves get messed up. We get that peripheral neuropathy, the tingling in the extremities. You get all sorts of damage in the autonomic nervous system and the brain. And of course, you have vascular damage other than just in the eye. You can have vascular damage in the kidneys, in the heart, in the brain, and practically anywhere else. So lots of stuff going on, lots of relationships that are connected either directly or indirectly, but there's a lot of stuff going on, a lot of moving parts when persons have diabetes. So this chart I thought was so cool to show. So now let's get into a little bit of the meat of what I want to talk about. What is diabetic retinopathy? Is it just when we see hemorrhages in the eye? Is it just when we see exudates and all the other things that we actually are looking for? Or is diabetic retinopathy other stuff too? I believe strongly, based on my clinical experience, based on reading these peer-reviewed articles that I've got referenced throughout here, that the modern definition of diabetic retinopathy should include diabetes-induced neurodegeneration. So it's going to be more than what we just see. And we're already used to that. We're already used to running tests on patients where we get information where it shows us things we can't see with the naked eye or we can't see with an ophthalmoscope or a regular white light camera. So we're already used to that. That's why it's so easy for me to accept and believe the science that talks about diabetes-induced neurodegeneration. So what is that? We've got retinal neurodegeneration. It's a response to hyperglycemia. And the first thing, and this stuff was so interesting, it took me quite a while to research this presentation and get it together, because as I started looking up stuff, every other thing that I found I didn't quite understand, so I would look up something and then I would have to look up what I just looked up. And this neurovascular coupling is an example. So when you have diabetes, part of the retinal neurodegeneration is that the patient can have a loss of neurovascular coupling. Well, I didn't know what that is up until a couple of months ago, and now I know that it's a process by which neuronal activity leads to localized increases in blood flow in the retina. So basically, as the retina starts doing stuff, the blood flow increases to support the increased metabolic demand. It actually makes sense. It's pretty easy to understand, and they call it neurovascular coupling. And when people get diabetes, that process gets messed up. You also get this neuroinflammation, nerve growth factor autophagy. You get biochemical alterations, including the oxidative stress. That's a real big thing in all the nutrition classes now, talking about oxidative stress and how do you try to relieve that with antioxidant supplements. You've got the formation of the advanced glycation end products. A few doctors like myself have that Freedom Meditech biomicroscope where we can measure those things in the person's lens. You get a selective loss of short wavelength cone photoreceptors. We'll talk about that in a little bit. Increased VEGF levels, and last but not least, an apoptosis of the retinal ganglion cells. All of this stuff happens to people when they get diabetes. It's not stuff that you can see, but it is definitely happening. And as these things, these abnormalities increase in severity, it begins to affect the person's vision. Then they start to lose vision. So again, I'm going to come back to this over and over. What is diabetic retinopathy? Is it just a bunch of blood and stuff that we see in the retina? Or is it all these other things too? And my position and the position of this lecture is that it's all these other things too. And that's how I think about diabetic retinopathy in 2017. So you have to always refresh and remember our basic science, the structure function relationships. And more we're going to describe all of the diseases that we monitor and treat and diagnose. What is the structure function relationship? We've examined it in detail in glaucoma. We're examining it in detail in diabetes. And we now know that there is a structure function relationship that exists between neurodegeneration and vision loss. And in lots of patients, you get this neurodegeneration that leads to vision loss, and it happens without you seeing anything. So you can have retinal neurodegeneration that produces measurable loss of vision, and the retina can look totally normal. There could be no hemorrhaging, no swelling, no exudates, no nothing. It looks fine, but there's a loss of function because of the neurodegeneration that you can't see. This neurodegeneration, according to these guys down here in this investigative ophthalmology article, said it could be a biomarker for subsequent damage. And last but not least, If you've got this neurodegeneration going on in the retina, clearly it could be going on in other parts of the body, other parts of the neural system. And again, you get that peripheral neuropathy and you get these neuropsychological disturbances. So people get kind of crazy sometimes because their brain's getting damaged. The blood flow is getting damaged to the brain. So all kind of stuff going on with the structure function relationships. You got to review that as we go forward. So how do you detect neuroretinal dysfunction? What kind of tests do you do? Well, it's these tests right here. So early diabetic neurodegeneration can be demonstrated with any of these tests: the color vision, visual field, dark adaptation, ERGs, and contrast sensitivity. You can also pick it up structurally by seeing decreased thickness of the ganglion cells. So all of us that have OCTs, where we can do that ganglion cell layer complex, that's real helpful here, and fall out of the retinal nerve fiber layer. And I don't, the slide here, we're doing this a week before the presentation. 2 days ago, I just got my brand new Zeiss OCTA, and I'm not giving Zeiss a commercial. I just want to say it, and I am so excited about what I'm going to start seeing with structural evaluations and blood flow with this OCTA in my diabetic patients. That'll be a whole nother lecture probably. So there's all kinds of ways of detecting neuroretinal dysfunction, and it's most significant to me again when the retina looks normal or the patient's got this vague non-specific complaints, and you say, is there anything wrong with my patient, or are they just acting funny today? Well, if they're diabetic, to me you can't say they're normal until you start running some or all of these tests to see if they have any neuroretinal dysfunction. You've got to understand the neural response of the visual pathway as you're running these tests to see what's going on. So as a quick review here, we've got our receptors. This is the neural response of the visual system. It's kind of our basic neuroanatomy and ocular anatomy when we were in optometry school, talking about the rods and cones. And since the topic of this lecture is color vision in diabetes, I wanted to concentrate on the color coding for color vision and these parallel ganglion cell systems that run through the brain. What you'll quickly see as we get deeper into the lecture, this lecture could be called Dark Adaptometry in Diabetes, ERGs in Diabetes, contrast sensitivity testing in diabetes. I can make a whole lecture for each one of these diagnostic tests. I can make a lecture for the OCT by itself. So I just decided to start with color vision because it's really good. It's easy to do. It's something that most of us are not doing. So I wanted to try to get some new information. It's extremely valuable. It's just as valuable as doing a visual field. No one of these tests really is a whole lot more significant than the other. It just depends on the patient as to which deficits you're going to have first. So again, you can't really run test and say the person's normal, because they could be one where dark adaptation is abnormal and the color vision's fine. But in the gist of this lecture for today, we're going to concentrate on color vision because we'd have to have a 5-hour lecture to include all of the tests and everything that we can see. So we're just going to get started. So our parallel ganglion cell system. So we talked about the neural response of the visual pathway. It starts with the receptors. Then as it goes to the transmitters, the optic nerve, chiasm, and tract, and so on. And the big thing here is, remember, the optic radiations, the pathways in the brains where the visual impulses are transmitted, are broken down or separated into 3 divisions: the parvocellular division, magnocellular, and coniocellular. And specifically, what we need to know is that color vision, since we're talking about color vision and how it's affected in people with diabetes, well, most of our color vision is transmitted through the parvocellular division. You see, that's what's going to transmit the red and the green. You got the red and the green cones. And our blue-yellow color vision is transmitted through the coniocellular division. The magnocellular division is achromatic, so it doesn't transmit any color vision information. And we usually talk about the magnocellular division when we're talking about the early diagnosis and treatment of glaucoma. We're talking about diabetes today, so it's the exact opposite. We're going to be talking about the parvo and the coniocellular. Those are the ones that transmit color or chromatic sensory information to the brain. This is a very interesting slide. I'm not going to read the text. You can read it later. But it's an example of the normal retinal cone distribution. And so you can see the ratio of red cones to green cones to blue cones. And it's really striking to me how few blue cones there are. And it explains almost so simply why most of the time when you have ocular disease, the blue-yellow vision is the one that's affected more often and more intensely because there's so few cones. It's so easy to mess them up. So just a real cool slide here on the retinal cone distribution. As we finish up talking about the neural response, remember you've got the visual stimulus coming into the eye, hits the photoreceptors, gets transmitted through the brain, and then the signal ends up in the primary visual cortex in the back of the brain, and that's where color vision and form and movement and all these other things are processed. And this is a really interesting and explanatory description. Our lateral geniculate nucleus, you can see here's the lateral geniculate nucleus right here. You see the different layers. So the parvocellular here, magnocellular down here. The coniocellular is this kind of white ground substance in between these slabs, so to speak. So it's kind of cool. So magnocellular, but there's a little conio here, a little conio there, conio here, here, and here. So the anatomy of the lateral geniculate nucleus, again, we learned all this in optometry school, and I remember I used to sit in class wondering, man, do I really need to know this stuff? Why do I need to know this stuff? Well, I'm glad I learned this stuff because here we are, or here I am, 33 years later, using this information to help diagnose conditions in my patients and to make decisions. I'm glad they taught it to me. We should all be grateful that they taught it to us. Let's keep going. So now we've got our basic science background. We've talked a little bit about diabetes. We've talked about what is traditionally considered diabetic retinopathy, which is the visible observation of blood and fluid in the retina secondary to diabetes. We talked about neurodegeneration and how you can have neurodegeneration going right along with the vasculopathy and you don't see the neurodegeneration. And we talked about how you detect it primarily with functional testing or with sophisticated OCT testing. So now we've got our background. Let's examine our patient with diabetes. Fortunately or unfortunately, however you want to think about it, almost all of us have lots and lots of patients with diabetes. Diabetes is essentially an epidemic in the United States of America as we speak. It's not going to go away anytime soon. As a matter of fact, it appears to be getting worse. We're going to continue to have numerous patients with diabetes coming into our offices every single day. So how do we examine this patient with diabetes? What's the modern way of doing it? I don't want to say the best way, that like I'm the best, but what is a good way of doing it? So the main goal when you're examining the patient, in my opinion, is number one, and this is how we're trained, this is what we're fixated on, we're focused on it like a laser beam. The first thing we're trying to do when we have a patient with diabetes is we're trying to determine the presence or absence of diabetic retinopathy. We're trying to see if our patient has a vision-threatening complication secondary to having systemic diabetes. That's the most important thing. It is to me, and it is to probably all of us. That's the way we've been trained. So that's number one. If diabetic retinopathy is present, now the way I practice is I'm going to classify the condition. Is it neurodegenerative or is it vascular? So to me now, there's two different types of diabetic retinopathy. There's the kind that we can see, that we've been trained to look for, the kind that they've been talking about for 100 years. Okay, we got that kind. But we also have a new kind, and it's right there, right alongside of it, side by side, this neurodegenerative kind. So now I'm going to classify the diabetic retinopathy. And think about this. Let's say the person has diabetes. I do my dilated fundus exam. I look in there. I don't see anything. So now I know they don't have any vascular stuff that I can see. Does that mean they don't have diabetic retinopathy? Clearly, the answer is no. Okay, clearly the answer is no. So first thing, do they have diabetic retinopathy? If they have it, what kind is it? It could be one, the other, or it could be mixed where it's a combination. Is there anything else that could be going on? And we've always had to do that. So if you had the patient that had diabetes and hypertension and you saw cotton wool spots in the eye, you'd have to determine if it was hypertensive retinopathy versus diabetic retinopathy. There's other things that can produce these retinal lesions, and there's certainly other things that can produce loss of vision, and the patient just simply may have diabetes as just off to the side. So you have to identify and exclude your differentials, and depending on what you see, prescribe a treatment program, and it may simply be surveillance examinations for diabetes. It may be surveillance examinations for diabetic retinopathy, which are going to be more frequent and generally more intense. You may prescribe nutritional supplements, diets, and exercise. We're certainly not giving anybody insulin shots, but I could do all this other stuff. If necessary, I can send them back to their medical doctor and hope that they're modern and tell them what I'm seeing and see if they'll get more aggressive with the treatment. And if I actually see something that requires intervention that I can't handle, then I'll send the patient to a retinal specialist. But I've got 5 things I could do there. So depending on what I see during my exam and depending on my test results, I'll pick one of those 5 or a combination of those 5 things to do. But it varies depending on what I see during my exam. So the whole case presentation will vary depending on what's going on in the exam. So now, to me, this is the top of the line, spare no expense, do it if you can, diabetic eye examination. The first thing you're going to do, of course, is an eye examination. You're going to look at the person's eye, you're going to dilate them, and you're going to look at their retina as best you can. Ideally with some type of fundus lens or binocular indirect ophthalmoscopy to get off into the periphery. That is an eye examination. There's no test involved. It is not extended ophthalmoscopy, no extra test, no extra money, none of that stuff. You're just examining the person, dilating them up, and looking in there. And sometimes that's enough and you can tell exactly what's going on. Usually to me that's a bad sign. If I can look in my patient's eye and in 3 minutes I can tell exactly what's going on in a negative sense, oh, that means they got all kind of stuff going on. That's all bad for them. If I could tell someone has glaucoma in 5-10 minutes, oh, that's real bad for them. So if it's hard for me to figure it out, usually it's good for the patient. If it's easy for me, it's usually bad for the patient. So let's say I do my eye exam. I've dilated them up. They look fine. Okay, so there's 2 things. They're either going to look fine or they're going to look abnormal. That's how we've been trained. That's what we're looking for. So we're looking for stuff. And if we don't see stuff, what we do now is we check off on our little forms, no apparent diabetic retinopathy. That's what the forms say. That's what mine say. And no apparent diabetic macular edema. And then we send that off to the primary care doctor and think everybody's okay and see you next year. And that's what we've all been doing. Well, I'm not practicing like that anymore because I've seen patients where I thought they were normal and it turned out they were not. And the way that you tell is you got to start running tests on them and actually see, and you got to prove that they're normal. And if they're not, then you figure out what's wrong with them. So let's say I do my eye exam. The person has diabetes, so I'm doing the diabetic eye exam. So I examine them and they look fine. Am I done? Yes or no? To me, most of the time, the answer is going to be no. Because now I'm going to do some other tests. I'm going to start with our standard optometric test, the refraction, and then almost always I'm going to go to the color vision because it's easy to do. I can get my staff to do it. I don't have to leave the exam room. I don't have to use any expensive technology, and it'll give me all kinds of information. So the first thing I do is I run an extended color vision examination on my patients with diabetes, even if they have 20/20 vision. If they tell me something in the case history, doctor, my vision's fluctuating. I can't see good in the morning. This left eye's got a film on it. Whatever, I don't care, something. If they say something that suggests any type of vision abnormality or loss of vision, then I'm comfortable initiating a diagnostic and treatment program and starting to run at least 1 or 2 diagnostic tests to get a little bit more information other than me just looking at them, because I already know now they could have stuff wrong with them and they can look just fine. So I could pick out of this list. I could pick electroretinography as my first test. Well, that's a lot harder and you got to have more expensive equipment, and everybody doesn't have one of those things, so I'm not going to pick that one first. I could pick dark optometry, but it'd be the same restrictions and limitations. That's why I pick color vision, and that's why we're talking about color vision in this lecture. It's not that it's more important, but it may have some benefits as far as ease of use and clinical value. These structural evaluations, most of us do fundus photography. A whole lot of us are doing wide field imaging with our Optos devices. A few of us, me included, are doing multispectral imaging with the Anitas technology. Almost all of us are doing OCT imaging, checking the macula, because we're always fixated on macular edema, trying to see if the macula's swollen. That's the main thing we're looking for. We're always looking for that. And if it's not swollen, it's like, yeah, that person's okay. And now, over the past few months, a few of us have started acquiring these brand new OCTs and doing this OCT angiography. And as I stated earlier, I've just acquired that technology, and I'm really excited about it. So to me, this is a diabetic eye exam. Now, I know that we can't do all this stuff on every patient. I'm not crazy. Okay, I know there's people with no money and no insurance. I'm not trying to say this is what you have to do. But I am presenting a top of the line start. You can start here and work your way down, as opposed to starting at the bottom and work your way up. So if your mother had diabetes, if my mama came in and had diabetes, this is what I'm doing to my mama. Okay, I'm gonna just say it like that. All right, let's keep going. Since we're talking about color vision, let's do a review quickly on acquired color vision defects. And this is not from diabetes. This is kind of the whole gamut of color vision defects. You see the little factoids over here on this left column. 15% of the population having general color vision defects acquired. A lot of times they don't know about it. When's the last time somebody came in and said, "Hey doc, I think I have a color vision defect. Would you please check my color vision?" "Hey doc, I'm mixed matching my socks. My wife says that my color vision is crazy. Would you please check my color vision?" Patients don't come in with that kind of stuff. So the patient is often unaware of changes in their color vision. So you cannot depend on them to report an abnormal symptom that involves a loss of color vision. That you can't do that. The patients can describe them in ambiguous terms and so on. So don't count on the patient, okay? The main thing I want you to know is that a lot of people, 15% of the people in the population, get some type of acquired color vision defect in the course of their lifetime. What we're going to talk about is the ones that's caused by diabetes. How do people get these defects? It could be structural damage. Usually it's structural damage. It could be pre-receptor, where you get changes in the lens, the crystal lens in the eye, changes in the absorption properties. The most common thing, and the one that we're talking about mostly, is the receptor cells get damaged, the red cones or the blue cones, and the ganglion cells get messed up. And of course, it could be, because we talked about early in the presentation, it could be post-receptor. You can have the retinal cortical neural pathways in the brain that go to the visual cortex. They could be damaged. Remember that slide I showed that showed all the interrelationships between the different types of damage? And you can get the retinal vasculopathy. You could get just neural vasculopathy in the brain. So it can get, the retina could be okay, and you could still have it in the pathways in the brain. There's different ways to get these acquired defects. We're talking about diabetes. So in the correct term is dyschromatopsia of diabetes. Dyschromatopsia is a loss of color vision, a loss of chromatic discrimination. That's the technical term. So there's a loss of color vision that's associated with people having diabetes. And these little factoids were, to me, incredible. And the first thing, that chromatic visual disturbance in association with presumed hypoxia precedes diabetic retinopathy in 55% of patients. Wow. I mean, that's almost worth saying again. So these guys down here that published this article in the Investigative Ophthalmology, so what they said, what they proved, and I've seen it with my own eyes, I mean, I believe it 100%, is that you can have a loss of color vision in a patient whose retina looks totally normal. So the loss of color vision precedes diabetic retinopathy. And when we use it in this context, we're talking about precedes diabetic retinopathy, where we're using the traditional definition of diabetic retinopathy, which is the observation of vascular lesions. What we now know is that this color vision test is simply detecting the neurodegeneration that is also present, which is a different type of diabetic retinopathy. See, it all makes perfect sense. It makes so much sense. It matches up perfectly. So this thing right here is what we talked about at the beginning of the presentation. You can also have atrophy, where it shows the retina is kind of shrinking, the cells are dying. 55 to 65% of patients with retinopathy have color vision defects, and of that group, 90% is blue-yellow. So these factoids are critical to know when you're trying to diagnose and treat your patients with diabetes and trying to figure out, does, it's easy to figure out when the guy's got hemorrhages all over the back of his eye, hey, this guy's got diabetic retinopathy. What if the guy's got 20/20 -3 vision and his retina looks normal? So does this guy have neurodegeneration secondary to diabetes, a different type of diabetic retinopathy, or is he just having a bad day? It might behoove us to run some tests on that patient, maybe starting with an extended color vision test, and let's see if this guy's got something wrong with him, as opposed to blowing it off and hoping he's okay. So that's one way to look at it. When you're doing this stuff though, you've got to remember when I talked about the goals of the diabetic exam, identify and exclude differentials. Well, you've also got this other condition called the dyschromatopsia of aging, which is, the yellowing of the lens, the change in index of refraction of the lens. And so you can have a loss of color vision, the yellow in particular, as the person develops cataracts. And we've all got countless patients that have cataracts and diabetes, or cataracts and diabetic retinopathy. So if you measured that person's color vision and somehow the color vision was abnormal, you've got to remember, hey, maybe if they've got some cortical clouding or some nuclear sclerosis, that can affect the results too. And so a loss of color vision may not be totally due or exclusively due to the diabetes or the diabetic retinopathy. So remember, there's other things that can damage color vision, just like other things can damage the ERG, other things can damage the visual field. But since we're talking about color vision primarily today, I wanted to toss this slide out there to just refresh you and remind you, hey, there are possible other explanations when we're testing our patients, and this is one of them. So we're talking about color vision testing. Remember with our color vision testing that it is non-specific, and you can get abnormal color vision over a whole wide range of conditions and neurologic and ocular diseases. So again, you can't just jump to it. If the person has diabetes and then you check their color vision and it's abnormal, hey, okay, they're connected. Well, they're probably connected, but you got to make sure they're connected. You got to just think about it for a minute before you just default to that. When we're testing vision, there's basically two types of tests. There's screening tests. We've all been touched with the Ishihara pseudo-isochromatic plates. Those things are essentially worthless for what we're talking about here. Then you've got the American optical plates, which are better because they have the blue-yellow testing. But this is old technology, pieces of paper. I'm in a paperless office. I don't want to use paper tests. So these screening tests don't have a lot of value for what we're talking about. What we're talking about doing is extended color vision testing. And this extended color vision testing, you do to assess the integrity of the retina, the optic nerve, the visual pathways. And there's several different ways or examination techniques to do this. The first and probably the simplest and the easiest, the one we're most familiar with, is the Farnsworth D15 panel. A lot of us have those in the office. I've got a couple of them. I use them as paperweights now. You can go with the Farnsworth Munsell 100 hue testing. I can count the number of optometrists in one hand in 20 years that I've met that have one of those things. So we're probably not going to be spending a whole lot of time talking about that. We can talk about anomaliscope testing, the gold standard, as it were. And I think, again, I can count on one hand the number of optometrists I know that actually have anomaliscopes in their office. Or we can kick it up a notch because it's 2017, and we can talk about some computer-assisted testing. So what I want to start off with our testing, and again, I'm not trying to give a commercial. I'm trying to present a better way, in my opinion, of testing a patient's color vision. I believe computer-assisted testing is the way to go for the future. There's multiple benefits, the self-administering and self-scoring, self-reporting. These computer-assisted programs are adaptive. It's like doing a visual field test where, depending on how you respond, the instrument takes the patient in a certain direction. So if you miss the first 3 or 4 plates on the red-green, it's going to give you more red-green tests before it goes on to the blue-yellow. So it's adaptive depending on how well or how poorly the patient is doing on the test. And it's in this particular test, this Color DX, you see it on the tablet there in the picture, is validated by the Naval Aerospace Medical Institute as comparable to an anomaliscope, so I don't need any more validation than that. So the thing works fine. I've had mine for 4 or 5 years. It works great. So this is the way that I would one of the ways that I would recommend testing a patient's color vision when you're really trying to see if something's wrong with them. Another way, and this way is really cool too, is the cone contrast test. And there's a couple of different devices that use this technique. It was developed in association with the United States Air Force, and it's a cone-specific contrast sensitivity test. And again, you can see it on the slide, but it uses contrast to detect the color loss, to determine a threshold for the color recognition. It's pretty easy, takes about 10 minutes, extremely accurate. To me, this almost is going to be the way to go in the future. If you can get this thing to where it's nice and easy to work and inexpensive. The ones that are out there now are good. A little bit expensive, maybe, just depends on the doctor, what's expensive and what's not, but extremely accurate, very good test. Either of these tests, the Color DX on this little tablet, or a cone contrast test that's available through a couple of different companies, these are the ones that we should use in the future to test patients' color vision, not these screening tests that we were shown and trained with in optometry school. Those things don't work for what we're trying to do. These things were designed to detect genetic red-green defects in young kids. We're talking about trying to detect acquired color vision defects secondary to diabetes in adult patients. And these are the tests that are that are better at doing that. The Color DX and the CCT test. Now let's finish up and talk about a case report, about a real patient. So I've got this real patient here, 64-year-old white male that came in for his annual diabetes surveillance exam. So that's the correct terminology. He's got a 20-year history of diabetes that appears to be well controlled. He's not complaining of anything. He's coming in because I asked him to come in every year because he has diabetes. He wears glasses. He has 20/20 acuity in each eye with his glasses. And as you see on dilated fundus exam, he has no visible retinal vasculopathy. So based on the appearance, based on the observation, which is really the standard of care, that's what the definition is today, whether it's right or wrong. So based on the definition, this patient does not have, quote, diabetic retinopathy. That's based on the appearance, based on the observation. I have the multispectral imaging device from Anitas. That thing is real cool, and I got it primarily for my patients with diabetes and macular degeneration, and in particular for the diabetic patients. What you do is you well, you look at all the wavelengths of light, but in particular the yellow wavelength, which shows the mid-retinal structures. It's tailored for detecting vascular abnormalities, particularly microaneurysms. That's what you almost always see early, the first milestone, the first thing in the natural history. So you're looking for microaneurysms, because the other stuff, the other types of hemorrhages and things that you would see with diabetes, you would see with ophthalmoscopy or with regular white light fundus photography. So we've all done that. So, again, I showed you that a second ago. It looked totally normal. So based on white light fundus photography here, and based on multispectral imaging with the yellow wavelength, this patient does not have any visible diabetic retinopathy. So he has no vasculopathy. That's what we see. And if we go back, so if we go back to there, so he has no vascular diabetic retinopathy. Does he have neurodegenerative? Well, the guy's got 20/20 vision. He looks like he's okay. I'd say, yeah, who knows? Maybe, maybe not. He looks good here. Wait a minute. So now, I did one test that was totally normal, but I've already said one test is not enough. I've said for most patients, if it was your mother coming in, would you run one test or would you run maybe 3 tests to make sure? So I ran one extra test, which is this multispectral imaging. I'd say that's a little bit extra. It was normal. So I could have called it a day, but I said, no, I like this guy. I'm going to keep going. I'm going to make sure. I'm going to make sure there's nothing wrong with this guy. So I pull out my OCT and I do a ganglion cell analysis, because I learned at the beginning of the presentation that a loss of ganglion cells, ganglion cell apoptosis, is a sign of neurodegeneration. It's a sign of retinal neurodegeneration secondary to diabetes. And lo and behold, on this guy's right eye, there is a very, very mild loss of ganglion cell complex right here, and you see it on the sector plot right there, that little one yellow slice there. So it's just just a smidge, just a little bit abnormal there. So you see it, you see on the right eye your sector plot being totally normal, and the little bit of yellow that shows up there is not clinically significant, whereas here this defect is. So now I have one thing that's normal, a second thing that's normal, but now a third thing that's abnormal. I don't really know if that's just the way he is. I had never done this test on him before. I don't know if it's from the diabetes. I don't know anything other than the right eye appears to have a mild loss of ganglion cells right here. That's all I know. And that the guy has diabetes. They may or may not be connected. But now that I've found something, I'm not finished yet. Now I got to keep going. So I'm gonna go ahead and do a color vision test because it's always easy to do and my staff can do it. And lo and behold, I'm testing this guy's color vision, and you see here on the right eye, there's a mild deutan and a mild tritan defect. Whereas on the left eye, the vision is totally normal. The color vision is normal. And so now, wait a minute, I've got an asymmetry here now. So now I've got a color vision defect in one eye and a normal color vision response in the other, clinically significant asymmetry that now correlates with my OCT test. So now I've got two things that says something might be wrong with the guy because he has diabetes, maybe. So now I'm going to keep going. I'm going to do a visual field since I've got that fancy perimeter down the hall. Well, that thing is normal. We've all seen a bunch of normal visual fields. I can't say there's anything wrong here. But just like with the glaucoma, the visual field in many patients may only reveal late stage or advanced damage. So who really knows there? I got a fancy ERG machine too, so I said let me check his ERG. We know that ERG measures the retinal activity and in particular the pattern electroretinogram, which is what I did on this test, measures ganglion cell activity. And without getting into a bunch of detail on how to interpret this ERG printout on this Evoke DX machine, both eyes are normal. And so if you look very to the bottom here, the test results indicate there's a significant response to the stimulus in both eyes. So I do not see a deficit in the ERG in either eye. So I'm like, man, well, what's going on here? So now I've got to review all of the information. I've got to review the patient's history. He's got a 20-year history of diabetes. He had normal acuity, a normal fundus exam appearance. He had a normal threshold visual field. He had a normal electroretinogram. He had an abnormal OCT and an abnormal color vision test. Two things abnormal. If you count the 20-year history of diabetes, he's got three things that are abnormal. I think that's enough. You know, two maybe would have been, maybe three's enough to where I could say there's correlation. There's probably something going on. And so I decided to make a physical diagnosis of early diabetes-induced neuroretinal degeneration in the right eye. To me, this patient has diabetic retinopathy. He has early neurodegenerative diabetic retinopathy in the right eye. It's very mild. It's not affecting his visual acuity. He's not complaining about it. But on two very sophisticated tests, I've got functional abnormalities that cannot be explained by any other mechanism. He doesn't have anything else wrong with him based on all of his other tests. There's no glaucoma. There's no macular degeneration. He didn't have a stroke last week. There's nothing else going on. The only thing that possibly could explain this is that it's from the diabetes or that's just the way he is. I can't tell which it is right now because this is the first time I've done these tests on this patient. But now I've got an excellent baseline, and I'm going to check it again in either 6 or 12 months. This guy's in such good shape. To me, he would be a once-a-year guy. There's little to no chance of anything bad happening to him in the next few months, or even 6 months from now. So that's probably a bit too aggressive. But once a year, I could easily, I could see once a year. I would repeat this battery of tests. Some or all of them. I certainly would repeat the two that were abnormal. I would repeat the color vision. I would repeat the OCT to see if there's any evidence of progression. And clearly, if there were evidence of progression, then I would do all the other tests. I would repeat the visual field. I would repeat the ERG. I would do whatever I needed to. And if they were abnormal, I'd repeat them. So you can't cookbook patients where you got, I'm going to always do these 5 tests. I'm going to always do these 3-2 tests. That's, to me, that's inappropriate care. But so you can't cookbook it. You've got to customize the care to each patient depending on the combination of the history, what you see in the clinical exam, your judgment, your experience, those things. So everybody's different. But in this patient, I say now he has diabetic retinopathy, and I reported all of these tests to his medical insurance with a diagnosis code of diabetic retinopathy. So how do I finish the visit with this guy? So now I'm telling the guy, on the one hand, I was about 10 minutes away from patting him on the back and saying, hey, you're fine. See you next year. No problem. I'll send your doctor a report. But now these 2 tests change the visit. And now I talk to the patient. I say, hey, I got to tell you, Mr. Jones, the test results today indicate a mild loss of vision in this right eye. I know you can't tell right now, and that's a good thing, but these tests definitely indicate there's a little bit of structural damage and there's a little bit of loss to your color vision in that right eye, and they match up. I'm thinking it's from the diabetes. So what we got to do is we got to get a little bit more aggressive with the diabetes if you can, the treatment, diet, exercise, medicine. Review again to me what you're doing. What's your exercise program? What'd you have for breakfast today? How's your diet going? When did you see your doc last? Are you taking your medicine every day? Those kind of questions and that conversation becomes much more intense when you've made this diagnosis of neurodegenerative diabetic retinopathy in a patient with no complaints. And if your patient trusts you and you can show him how the tests all correlate, it all makes perfect sense. And the guy understood everything I was saying to him. So the last thing, what is diabetic retinopathy? Is it a retinal vasculopathy, or is it neurodegeneration? Which is it both? To me, it's both. So do we move beyond this standard thing we're doing now of taking fundus photographs, and if you're real special, then you go ahead and do an optos? Okay, fine. So do we move beyond that? Because it's still just fundus photography. That's all it is. It's fancy fundus photography, but it's all it is. So do we move beyond standard fundus photos and ophthalmoscopy to diagnose early diabetic retinopathy, or do we start adding this functional testing into our diagnostic testing protocol and actually make the correct diagnosis, the early diagnosis, the more accurate diagnosis of neurodegenerative diabetic retinopathy by detecting functional loss of vision with our color vision test, the visual fields, ERGs, or these others, or early structural loss like we'd see with our OCT or the angiography? That's, you've got to make that decision. I've made mine. I'm going to challenge you to make yours. So in conclusion, chronic metabolic alterations caused by diabetes can lead to neurodegeneration and vasculopathy. And in some patients, this neurodegeneration, it occurs before, independent to, or in addition to vascular lesions. And if you ignore these early signs of functional loss, you could then have a patient that gets permanent vision loss, which is almost what we've sworn to not let happen with our oath, and to control test variability. And that's what I did with this patient, the example I used. Each patient becomes their own control subject. And the reason, everybody's different. You can have 10 people with diabetes, run all these tests on them, and have 10 different outcomes. Everybody's different. There's no rules. Some patients with diabetes are going to have abnormal color vision, and all the other stuff will be normal. The next patient could have an abnormal ERG and the color vision could be fine. The very next patient could have an abnormal OCT and the visual field is okay. There's no rules. So everybody's their own experiment, their own test, and they're their own control subject. So you do is you establish a baseline, and then you check them in a year or 2 years or 6 months, whatever your protocol is going to be, and that change over time becomes your measure of, is the disease active, yes or no, not what you see. So there's other ways to look at this stuff, other ways to measure it, other ways to follow it, and based on the results that we get on the test, other ways to treat it even though we're not prescribing the metformin, even though we're not giving them the shot of insulin, there's all kinds of stuff we can do, and especially now with the nutritional supplements that affect diabetes and how you can modify the progression of the disease. There's definitely things that optometrists can do to alter the course of the diabetes in their patients. And if we keep thinking our patients are normal when they are not, then we're not doing the best job that we can to protect their vision. And it's so easy for us to actually kick it up a notch and do better. And one of the simplest, easiest things we can do is to begin to incorporate extended color vision testing into our patients with diabetes and diabetic retinopathy to get a much better idea of the status of their retina, their vision, and their visual system. So that's what's going on. That's what I wanted to talk to you about today. I hope it all made sense. That you got two different kinds of diabetic retinopathy, and we can diagnose and treat both of them. So thanks for listening. Hope everybody enjoyed it and learned something, and I'll be available for questions for the next hour.